afternoon, good morning to the colleagues who are in the United States. Thank you everybody for joining this lower extremity trauma course. It's a virtual education conference that we've organized on behalf of World Orthopaedic Concern and the Harvard Global Orthopaedics Collaborative. So this session will run for about 2.5 hours. That's my expectation, to 3 hours if necessary. And we really have some excellent faculty from Libya and from Harvard who are here today who will be sharing their experience and their expertise. So first, before we begin, I'd just like to introduce my co-hosts. So obviously my name is Dr. Kiran Agarwal-Harding. I'm from the Harvard Global Orthopaedics Collaborative. The co-chairs are Dr. Allah Ahmad from World Orthopaedic Concern and obviously Dr. Ayman Bouagrara from Libya. I would also like to just acknowledge the HGOC organizing team. These were the people who helped us record all of our videos, prepare all of our documents, curate our articles, send out emails, organize all of this stuff. So a really big thank you to Dr. Sohail, Dr. Aaron, Dr. Jason, Kush, and Sam. And you'll see them in the call. They'll be helping us as we go along. So just to introduce, this is our agenda for today. Just a very brief welcome and introduction from myself this morning, and then we'll get right into it, into the educational topics of the day. So we have a journal club, which will run for about an hour, case presentations, which should run for about 1.5 hours, and then just open questions and a conclusion, just open discussion afterwards. So just a brief moment to talk about this, Zoom etiquette. The nature of these virtual conferences, it's tough, obviously, to feel that we are with one another, speaking to one another. So that's why I think it's nice if we can turn on our video if possible. I understand that with internet problems, that can be an issue, but that would be nice. Also, please, just for the purposes of everybody's sanity, please keep your microphone on mute unless you're speaking. Okay, that'll make it a lot easier for everybody. The chat function, the chat box, that's open to everybody. So please type your questions. We have a team that is moderating the chat. We'll respond directly and we'll respond live. And then if you would like to make a comment, just please click on reactions and raise your hand, and then we'll try to work you into the conversation, okay? So just very briefly, these are our course objectives. We really are first and foremost trying to improve the participants' knowledge of lower extremity trauma management principles. That, of course, goes without saying. But we are also trying to foster this international discussion regarding orthopedic trauma care delivery between our colleagues in Libya and us at Harvard. And we're trying to motivate and support particularly Libya's younger generation of orthopedic surgeons. This conference is really for the younger generation, most of all. So just as a brief overview, again, this is the course structure. You guys are all familiar with this now. So for the past week, you've been doing self-directed learning based on the lesson plan that we sent out. And here we are at session 1. For those of you who aren't familiar, don't worry, you have a whole nother week to get used to it. We have another week of self-directed learning coming up next week with the live session on Saturday, and then a third week as well. Each week we'll have a different topic, different faculty members, different case presentations. I really am excited for the live sessions. I think it will be very exciting. And as you know, the self-directed learning, we have recorded lectures, which are really phenomenal by some excellent faculty members, 4 articles for journal club discussion, which we will go over today, and then a whole bunch of supplemental articles. So these are articles that talk about techniques, they talk about scientific discoveries, they are review articles. These are articles that we've specifically curated that we think are helpful for understanding these topics. So we encourage you to get them. Everything's free as long as you register. So this week, we had some excellent recorded lectures by Dr. Eric Blumen of the Brigham, Dr. John Kwan of MGH, these are both Harvard hospitals, Dr. Gonzalo Bastias of Chile, and Dr. Rajiv Shah from India. So I hope that everybody had a chance to watch these lectures because they were really fantastic. I learned a lot from them. So today's session, we'll be going over talus fractures, calcaneus fractures, Lisfranc injuries, and subtalar fusions. And so without further ado, Ayman, I don't know if you want to say a few words before we begin, but I thought we could start off with the journal club. Ayman, I'll leave it to you. Do you want to say anything before we begin?
Thank you. You described everything and we can proceed. Thank you very much.
Thanks, Ayman. Okay, so today for the Journal Club, we have 4 articles that we will be discussing. The first is on talar neck fractures. Then we'll move on to the one on wound complications after calcaneus fracture fixation. Then we'll talk about primarily ligamentous Lisfranc injuries, combining open reduction versus primary arthrodesis. And then we'll move on to Buckley's article about open reduction, internal fixation versus primary subtalar arthrodesis for these type 4 calcaneus fractures. So these are the residents and the faculty members that Ayman was kind enough to volunteer for each of these articles. So whenever you're ready, Dr. Al-Ghul, Dr. Al-Gandos, please take it away and you can discuss the first article on talar neck fractures.
Hello, my name is Mohammed Amran Ghul. Do you guys listen to me?
Yes.
Are you here? Okay, thank you very much. My name is Dr. Mohammed Ghul. I'm a orthopedic junior resident in a Muslim trauma hospital in Tripoli, Libya. And I will be talking about the article about the talar neck fracture, results and outcome. Is the voice okay? Okay, thank you. We're talking about the talar neck fractures, which occurs infrequently and have been associated with high complication rates. The purpose of the present study were to evaluate the rate and early complication after operative treatment of the talar neck fracture to ascertain the effect of the surgical delay on the development of osteonecrosis and to determine the functional outcome of the operative treatment of such fractures. The article reviewed records of 100 patients with 102 fracture of the talar neck who has been managed with a level 1 trauma center. All fractures have been treated with the open reduction and internal fixation. 60 fractures were evaluated at an average of 36 months, ranging between 12 to 74 months after surgery. Complication and secondary procedure was reviewed. Radiographic evidence of the osteonecrosis and post-traumatic arthritis was evaluated. The foot function index and the musculoskeletal function assessment questionnaires was administered. As a result, the radiographic evidence of osteonecrosis was seen in 19 of the 30 out of the 39 patients, which makes about 49%. However, 7 of those 19 patients demonstrated revascularization of the talar dome without collapse. Overall, osteonecrosis with collapse of the dome occurs in about 31% of the 39 patients. Osteonecrosis was seen in association with 9 of the 23 Hawkins group 2 fractures and 9 of the 14 Hawkins group type 3 fractures, makes about 64%. The mean time for fixation 3.4 days to patients who have developed osteonecrosis compared to 5 days for patients who did not have development of osteonecrosis. With that number available, no correlation could be identified between the surgical delay and the development of osteonecrosis. The osteonecrosis was associated with a comminution of the talar neck and open fracture. 21 out of the 39 patients has developed the post-traumatic osteoarthritis, which was more common after comminuted fractures and open reduction. Patients with comminuted fracture also had worsened functional outcomes. And the paper concluded that the fracture of the talar neck are associated with the high rate of morbidity and complications. Although the number of the present series were small, no correlation was found between the timing of the fixation and the development of osteonecrosis. The osteonecrosis was associated with the talar neck comminution and open fracture, confirming that high energy injuries are associated with more complication and worse prognosis. The finding was strengthened by the poor foot function index and the musculoskeletal function assessment scores in those patients. The article recommended that the urgent reduction of dislocation and the treatment of open injury proceeded with definitive rigid internal fixation of the talar neck fractures after soft tissue swelling that has been subsided may minimize the soft tissue complication.
Very good. That was a lovely summary. Thank you for that. So
Thank you.
May I invite your faculty member to comment about how talar neck fractures are perhaps managed in your setting? Is this something that you see commonly? Is this the main thrust of this paper, from my gathering, is that they advocate for doing a medial approach to prevent that varus malunion of the fracture. They talk about avoiding early open intervention because they believe that it's associated with not only wound complications, but also osteonecrosis. And they advocate for doing an early close reduction and percutaneous reduction, but then doing only your open fixation when the soft tissues are a little bit better. Is this something that you guys typically do? How do you think about talus fractures in your setting?
Okay, Dr. Farouk.
Okay, Bismillah ar-Rahman ar-Rahim. First, I would like to thank Dr. Karen and the Harvard University for joining us this a big talk, which we are sharing our knowledge. And in the meantime, I would like to thank all the audience who are hearing here. We are trying to solve some issues which is always facing us in our hospital or other hospitals. In terms of talar fracture, usually in my hospital, it wasn't a common injury which we face, but we have many cases treated in the hospital. Usually the main standard we use, we do a close reduction first, and then we go for further internal fixation, as the articles mentioned here. In terms of the approach, usually we go for the double approach, anteromedial and anterolateral, but in some few cases, whether we do percutaneous or we do just anteromedial to avoid the varus malunion. What I want to say in this article, actually, this article is quite perfect in terms of information about the talar neck fracture. This is a comprehensive study which is trying to cover all the talar fracture, but in the meantime, there is a lot of variables in this study, and these variables make the statistic, it's a bit of less accuracy in terms of statistically, that's in my opinion. But it covers so many subjects, and it has many variables in this study to cover. The main concern it's included in this study is the the complication of talar neck fixation, because the fixation method, it's not really covered here, but I mean, it is a standard for everybody to know how to go for the talar fracture, but whether this is the right or not, that's what's discussed here in the articles, which gives a good clue for us what at the end of this study what we will do for the talar neck fracture in terms of complication. But in the meantime, still the complication is not covered as a whole, because I told you the variable is too much, and this is not I mean, this gives the power of the study is less than what we expect to be. For this study, it covers the complication of in terms of the osteonecrosis, and in terms of the functional outcome, and in terms of the the joint collapse and arthritis, whether it's subtalar, whether it's tibiotalar or talar arthritis. And this is the main subject which is affecting our functional outcome for the patient. And this is what we want to cover and we want to do and to read. But in the meantime, we don't know in this study whether we have to go early for fixation or not, because the time of injury and the time of fixation, it's not recorded here in this study, as it's a retrospective study, so we don't know whether they have gone straight away. I mean, the patient attended to the hospital at the same time of the injury or not. So in brief, that's what I can comment about the the study in terms of the power of the study, but in terms of the knowledge, actually, we have gained a lot of information from this study. It's covering the whole talus fracture in terms of the methods of fixation, in terms of the timing. I'm trying to get some information about the timing when we fix and we will not. In the meantime, the what you call the method of fixation, what we have to do in talus fracture, when it's comminuted, when it's open, when it's closed, when it's displaced or not. So all this, I think we get it from this study. And in the meantime, complication we try to avoid. It is a good idea to get from this study. What do you call the impact of the timing for the whether we go early or not? Actually, it's still not clear, and I think there needs so many studies to go on to find out whether it is a complication or not. Because here, just we take the patients which are attending to the hospital and treated intraoperative open reduction and internal fixation. In the meantime, we don't know whether these patients, if it's treated straight away, will give the same result or not, or if it's just kept the patient even and this what do you call reduce whether there is effect or not. So, but ideally, the term any intra-articular fracture, when it's dislocated or displaced or subluxed, you have to return back to get a good vascularity for the joint. In the meantime, you get a congruency of the joint, which is important function. For the whole that what I get from the study and what I can discuss, I will open the discussion if anyone can give any comment further in this study, because I guess that's what I can see in terms of this study. Dr. Kiran, do you have any
Yes.
comment or any?
Dr. Farouk, that was fantastic. I do have a few questions for you, but before I begin, I was wondering if maybe I could ask Dr. Blumen, who's on the line and gave our fantastic lecture on talus fractures that was recorded, if maybe he has any comments on this paper.
Yeah, thank you very much, Dr. Farouk. That was a very insightful summary and analysis, and great summary by Mohammed. I suggested this article because I think it doesn't perfectly, but I think strongly refutes a myth, I guess we'd have to call it, where it was in my training, it was very important to address the talar neck fracture immediately. And I think that the article presents some strong evidence, albeit not perfect evidence, that if a reduction is obtained, or if a reduction is not needed, that the urgency of addressing the talar neck fracture operatively is much less so. I think it does emphasize that it's important that these injuries, which can, I think, easily be missed in a trauma setting, need to be found, and we need to be very vigilant to make sure that fractures and certainly dislocations are not missed and are addressed in a timely fashion, and that a reduction, hopefully in a closed fashion, is done, and if need be, in an open fashion. I agree with Dr. Farouk in terms of it's not a perfect study. It leaves some things to be improved upon, but I think it does show that we need to be very vigilant for comminution and for dislocation. What's interesting about the article is that although there were a good number of fractures, and this trauma center where the study came from has a huge catchment area of many thousands of kilometers, that the numbers still are not what we would hope in terms of getting us answers, but it may be the best that we're able to get because of their ability, and because they attract so many patients. They handle so many patients. I thought it was also very interesting that no CT scans or MRIs were done in many of these cases. And so this is a tool that we can use, hopefully, to be better informed about the comminution and displacement and dislocation of these fractures. And that we need to balance, as Dr. Farouk said, we need to balance the complications that certainly occurred with these fractures versus going early, and that it may be, if we are in a good spot in terms of the patients, temporizing the patients with a closed reduction or limited open reduction, that we wait to help to minimize complications in the perioperative period. I'm sorry that was long-winded, but I hope that there's some takeaway messages there.
No, that was great. So Dr. Farouk, you brought up a very interesting point about how we don't necessarily know how delayed patients were before they came to the hospital. So, you know, in my experience, a big problem in many parts of the world is that it takes a long time for patients to arrive. In the United States, especially in a big trauma center like the one that was studied in this paper, that perhaps is less of an issue. They have an emergency medical system that gets these patients to the hospital quite quickly. But as Dr. Blumen said, one issue is missing the diagnosis early. And so in the United States, when we have delayed treatment, delayed is usually because of a miss on our end, you know. But I can imagine in other parts of the world, the delay may come because the patient doesn't get to the hospital in time. There's no access to the hospital. There's a delay in getting the ambulance. There's a lack of knowledge that this is an injury that requires going to the hospital. Is that something that you experience in Libya, Dr. Farouk? And if so, what is your experience managing patients who may come late with these injuries?
Yeah, Dr. Karen, this is a very important point. Even I didn't share for that. It is always a missed injury. Usually when the polytrauma patients, sometimes we miss the patient, even in terms of diagnosis, the talar neck fracture, and then we comes late for that. But in terms of follow-up, we don't have a very long follow-up for the patients in Libya. And I guess Dr. Ayman, he mentioned to you all the idea about that. We are trying to find the patient follow-up, trying to follow the patients whether there is any compromise in terms of the functional outcome, and if the X-rays we do have some osteonecrosis or the collapse. I am not foot and ankle surgeon to give you a exact clue in my hospital, but in what I can see in my hospital with the patients, the osteonecrosis is quite a high, what you call complication rate, but we don't have what you call it calculated idea about that to give a study in terms of what I can give you from my hospital. But in the meantime, the treatment, usually when we find a patient with the talar neck fracture, especially if it's whether it's displaced or dislocated, we do a reduction first, and then we go for internal fixation later. In some cases, which is quite, we call it quite simple case, or we do have a space to just fix with the screw, we can go in the same day. But usually the other cases always going for the late fixation, internal fixation.
Gotcha.
I don't know whether I answer you or not.
No, it's interesting to understand the setting there, Dr. Farouk. I see that Dr. Gwila has his hand up. Dr. Gwila, would you like to say something?
Yeah, hello.
Hi.
Hello. Yeah. Just thank you for all the effort you made to Libyan faculty to join the International Orthopaedic Society. Yeah. So regarding the experience in talus fracture, yeah, we face some problems as you mentioned for trying to manage the patient, because most of the patients they come to the hospital late, and some missed cases, because in Libya, it's a huge country, too many hospitals we have. So the patient try to seek the best place. So maybe some cases missed. So I faced some cases that missed, we fixed them late. I mean, by MIBO technique, and some we did open, but the outcome, we don't have long follow-up term, because the most of the patient, they defaulted follow-up in the hospital. But so far, immediate post-op, the result very nice, and the most of the people satisfied. But the issue, we don't have long follow-up. Thank you.
Thank you. That's very interesting. Well, we could keep talking about talus fractures, but we have several other articles to get to, and we'll certainly come back to talus fractures in our cases. So maybe now we could move on to the next article, unless anybody has any further comments for this one. Could we move on to the article by Dr. Kwan? We're lucky enough to have him in the audience today to comment on this article himself. So Dr. Tariq and Dr. Mohammed El-Kasher, if whoever is willing, please go ahead and present this article.
Okay. Is it clear?
Yes.
Yeah. Okay. Thank you. Thank you, all faculty member, Dr. Tariq and Dr. Karen, from Zaytin Medical Center. I would like to present this article that published in American Orthopaedic Foot and Ankle Society since 2015. This article, the title of this article is Effect of Delayed with Defective Surgical Fixation on Wound Complication in Treatment of Closed Intra-Articular Calcanean Fracture. That the author was Dr. Kwan, Italy. Okay. Calcaneus fracture is the most commonly fractured tarsal bone, making up approximately 2% of all fracture. Male are disproportionately affected, as are younger individuals, with a peak incidence in the third decade of life. Approximately 30% of such fracture occur in manual labor, 2% are work related. Among heavy laborers, 25% are unable to return to work, and the remainder frequently do so at diminished level. In background, there are, sorry. Sorry. There are conflicting data regarding the benefit of delay operative fixation of calcaneal fracture to decrease wound complication rates. The purpose of this study was to examine the effect of delaying fixation of wound complication rate, as well as to identify other risk factors. Is my shares okay?
Yes, go ahead. Please continue.
Okay, thank you. The aim of this study is to assess whether delaying operative fixation of intra-articular calcaneus fracture resulting in decreased wound complication rates, and whether other factors, including the basic demographics or medical risk factor, fracture severity, operative approach, primary subtalar arthrodesis, and surgeon experience impacted in this wound complication rates. And the method, type of this study is retrospective level 3 retrospective study, observation study. Duration of this study is 10 years duration, including criteria. Inclusion criteria was equal or more than 17 years old of age, who sustained closed intra-articular calcaneus fracture and underwent operative fixation. Exclusion criteria, patient under 15 years or open fracture, and those who underwent initial external fixator are excluded from this study. Sample size is 405 patients. And demographic data, the average age at this presentation was 45 years. 80% was male and 20% were female. Risk factor, there are many risk factors including in this study, just like history of smoking, about 33%, including this study, 5% diabetic, 0.5% has rheumatoid arthritis, and there is post-operative non-compliance about 0.7%. Approach, there are many approaches for calcaneus interarticular fracture, which is an extensile lateral approach, which was 55%, science star psi approach, 39%, percutaneous approach, 5%, and there are some patients had primary subtalar fusion, about 8%. There are the classification of these fractures according to the Sanders classification. About the most patients have type 2 Sanders classification, about 52%. One complication, about 21% had a wound complication substratified into 4 categories on the treatment rendered. There are superficial infection, about 7%, deep infection, 4%, superficial dehiscence was 1 and necessitate local wound care, about 11%, and deep wound dehiscence was 1 necessitate return to operating room for any further procedure. All operative procedure and post-operative evaluation were performed by staff surgeon with either trauma or foot or ankle subspecialty training. Surgeon experience was certified into categories designed as junior, about 14%. The most surgeon is done by intermediate level surgeon, about 9 to 15 years working in the orthopedic field, about 58% done. A result, one complication were observed in 21 best as I said, of fracture, which 33 require operative intervention. Male 80%. Approach, extensile lateral approach were associated with higher complication rate. A fracture treated with extensile lateral approach had overall wound complication rate of 32%, while those treated with sinus tarsi or percutaneous approach had an overall wound complication rate about 8%. There's a p-value is significant here. Among patients treated with extensile lateral approach, delayed operative fixation didn't decrease wound complication rate despite comparative fracture severity across time point. In contrast, among fracture treated with less invasive approach, delayed fixation beyond 2 weeks result in significant increased wound complication rate of about 15% compared to wound complication rate of only 2% among fracture treated within a week of injury. This was observed despite similar fracture severity across time point. Primary subtalar arthrodesis didn't impact complication rate. A higher wound complication rate among senior surgeons was likely secondary to their predilection for extensile lateral approach. There are significant association between the operative approach and wound complication rate. Fracture treated with extensile lateral approach had overall wound complication rate about 32%, while the other that treated with sinus tarsi approach or percutaneous approach had overall wound complication rate about 8%. Fracture severity are defined by standard grade. However, was higher among fracture treated with extensile lateral approach. The time of surgery, time to surgery, delay to operative fixation appear to increase wound complication rate across the entire cohort. There was observed increase in wound complication rate with delayed operative fixation then when comparing results at 0 to 7 days and greater than 14 after the injury. Patients who underwent operative fixation using sinus tarsi or percutaneous approach more than 14 days after the initial injury were 3 times as likely to develop wound complication than those who underwent operative fixation the first week. That's statistically significant.
Thank you, Mohammed.
This demonstrates the delays. Okay.
Just
okay. Just 2 minutes.
If you could, if you like reading this paper, what is the most important point that you took away from this?
Sorry.
What was the most important point that you took away from this paper?
Yes, about the injury, delay operative fixation and related to the complication that occurred.
Right, and it has a lot to do with the approach, right? And
yes, approach. Yes, extensile lateral approach or sinus tarsi. The difference in those.
Right, exactly. So we're lucky enough to be joined today by Dr. Kwan, who wrote this article. John, would you like to comment a little bit on sort of what you think the key takeaways from this study were, and how has this paper, how has doing this research paper influenced your practice, and how would you hope that it influences others?
Yeah, absolutely. Well, thank you, Kieran, and the rest of the team for putting this meeting together. I'm very honored to participate. And Mohammed, thank you for the thoughtful review of this paper. So, you know, we did this study because we really wanted to try to better answer how time from injury to time to surgery affects wound complications. And this is certainly not a perfect study. It's retrospective. And even prospectively, you know, we have troubles classifying the condition of soft tissues. So retrospectively, we had to do it by treatment rendered, which I think is a fair way to do it retrospectively. But I think we were able to show with statistical significance that the extensile lateral approach, certainly the workhorse, and I do use it in my practice, but some of the wound complications may be inherent to that approach. As we know, you have to elevate a big flap. We've been taught to delay surgery by 1 to 2 weeks. And during that time, the shortened heel, the soft tissue envelope contracts. And, one of the things that we all find when we treat these patients is that wound flap is difficult to close. And that's partly because of contracture of the soft tissues, but we've also restored the calcaneal architecture. And so it's difficult to close. And I know sometimes we bundle infection and dehiscence as one thing, but in my experience early, a lot of these were more wound dehiscences than infections. And so we wanted to see how the sinus tarsi approach influences this. And similar to the other literature, we were able to find that the sinus tarsi approach has decreased wound complications. And interestingly, is safer to do early. And so, I think that this is an approach that we should all learn. There have been studies to show that you can visualize the posterior facet as well as an extensile approach. Just some of the other fracture reductions have to be done indirectly. I did find that when I started to do the sinus tarsi approach, it is much harder to do in a delayed fashion. And that's likely secondary to fracture consolidation. So Our hopes in publishing this were that we would somewhat change the dogma that calcaneus fractures have to be delayed, when in fact, if doing a minimally invasive, safer approach, it is safer for the patients and easier to get the reduction doing it early.
So that's thank you, Dr. Kwan. The question that I had reading this was, you show that there's an increased rate of wound complication with delay for those patients who receive the sinus tarsi approach, right? So I'm curious as to why you think that that was the case. And I'm also curious, and Dr. Guilla has his hand raised, so maybe he can also comment on this. In a setting where you may see patients presenting late, these injuries may be missed, they may present late. Does your paper strangely make the argument that perhaps in a delayed case, when patients are showing up to the hospital late, we should not be doing the sinus tarsi? Would you take the argument that far?
Yeah, I agree. Delayed presentation of displaced calcaneus fractures is a very difficult problem. And one of the problems with the sinus tarsi approach, given the limited visualization, is when you have increasing fracture consolidation, it's much harder to get your fracture reduction. Okay, so I do think that when patients show up delayed, we should be doing either an extensile approach, or we should be considering a subtalar fusion with possible corrective osteotomies as needed. And so there is a bit of a time window, maybe a week or two, that after the sinus tarsi approach becomes a bit more difficult. To answer your first question, yeah, we postulated on why the wound complication rate increased when we were doing the sinus tarsi approach when you had a delay. And I think that is because treating the fracture early, the reduction is very simple and straightforward. Take, for example, that tongue type fracture where the skin is threatened and we're going to the operating room that day. We can reduce that fracture percutaneously, and it's very easy to reduce. But once fracture consolidation sets in, when you're working through a very small incision, we thought that you're putting more tension on the incision, which we know is not good for wound healing. So I think that the increased fracture consolidation increased wound complications because of the increased tension on the soft tissues.
Thanks. Dr. Guilla, please go ahead. You have your hand raised.
Yeah, thank you, Dr. John, for a wonderful paper and all your group. I have some appraisal regarding this paper. I have gone through this paper, but you didn't mention about the prophylactic antibiotic for all the patient before the surgery. Did you clarify why in your school or your center you delayed the antibiotic? Second question is, as I don't have much experience about the sinus tarsi approach, because for me it is like a narrow access for the calcaneus fixation. In this case, we need to do primary ankle fusion, or what you think? Thank you.
Yeah. In the United States, it's really a standard of care, essentially mandated that patients get preoperative antibiotics before surgical procedures. We did not specifically verify that, but I'd hope that most patients did have that done, so that would not be a potential confounder when looking at our data. We had 4 centers, and so this was done at the Mass General, the Brigham, Carolina's Medical Center, and Mark Meyerson's group. And so we, especially in a retrospective manner, timing of surgery and the approach was really based on the surgeon preference. So we were not able to control for that.
Thank you. That was a great discussion. For the purposes of time, let's move on to the next article, Lion Coates's article on the treatment of primary ligamentous Lisfranc injuries. So Dr. Ali Mohammed and Dr. Sanad Younes, I'll give the floor to you if you would like to present.
دكتور علي.
دكتور علي، دكتور سند، دكتور علي معاك؟
المفروض انه موجود. دكتور علي وين؟ دكتور علي. دكتور علي.
All right, well, we can wait a little bit for them to come back onto the phone. Maybe we can move on to Buckley's article then in the time being, especially since I think it continues the topic of calcaneal fractures and talks about arthrodesis. So Dr. Ahmed El-Hijaji and Khaled Anaiba, are you available to talk about the Buckley article?
معاك يا دكتور.
Dr. Ali is here, eh?
Oh, okay, all right. Go ahead then. You can talk about the Liz Franklin.
I think, Dr. Khan, it is not the other article will Dr. Ali talk about. I think this is this article Dr. Khalid will talk about.
Okay, all right. Well, whoever would like to talk about this article, let's talk about that one then.
Dr. Ali, are you ready?
Inshallah, ready, yes.
All right,
Okay.
go ahead.
Okay. Okay, you can start.
Go ahead, Ali. Start.
Assalamu alaikum. Thanks for this opportunity. This study is a prospective randomized study comparing treatment of primary ligament Lisfranc joint injuries, comparing by primary arthrodesis and open reduction and internal fixation. Open reduction and external fixation is as I said before, this study is prospective study. Open reduction and external fixation is currently the accepted treatment of displaced Lisfranc joint in injuries. However, even with anatomic reduction, the objective of this study was to compare primary arthrodesis with open reduction and internal fixation for treatment of primary ligament joint injuries. 41 patients with an isolated acute or subacute primary ligament Lisfranc joint injury were enrolled in a prospective randomized clinical trial comparing primary arthrodesis with traditional open reduction and internal fixation. The patients were followed for an average 42.5 months. Evaluation was performed with a clinical examination, radiographic, the American Orthopaedic Foot and Ankle Society mid-foot scale, visual analog pain scale, and clinical questionnaire. The result of this study: 20 patients were treated with open reduction and screw fixation, and 21 patients were treated with primary arthrodesis of the medial 2 or 3 race. Anatomic initial reduction was obtained in 18 of the 20 patients in the open reduction group and 20 of the 21 in the arthrodesis group. At 2 years post-operatively, the mean of American Orthopaedic Foot and Ankle Society mid-foot score was 68.6 points in the open reductions group and 88 points in the arthrodesis group. 5 patients in open reduction group has persistent pain with development deformity or osteoarthrosis, and they were eventually treated with arthrodesis. The patient who had been treated with primary arthrodesis estimated that their postoperative level of activities was 92% of their pre-injury levels, whereas the open reduction group estimated that their post-operative level was only 65% of their post-operative pre-operative level. Conclusion: primary stable arthrodesis of medial 2 or 3 rays appears to have better short and medium-term outcome than open reduction and internal fixation of ligaments sprain joint injuries.
Thank you, Dr. Ali. That was a great summary. So I'll invite any of the Libyan faculty members to comment. Is this typically how you treat ligamentous Lisfrancs in your practice? Are you doing primary arthrodesis, or are you preferring ORIF?
Dr. Sanad, Dr. Sanad, he can.
Okay. Hello, everyone.
Yes.
Can you hear me well?
Yes, perfectly.
Actually, here in Libya, we usually use open reduction and internal fixation in cases of Lisfranc injury, whether it is a ligamentous injury or a bony injury. But in most cases, I have seen in the outpatient, especially in the old ladies, came with metatarsal arthritis, which could be due to missed undiagnosed ligamentous Lisfranc injury. So it's, I think it's more than 20% the number of cases, or the percentage of the cases missed from the casualty department. The point I would like to comment about this study is the first is the advantage of this study using two groups with similar age, almost similarity in the age and gender. But the points I would like to comment about is the first is the way of randomization in this article. They're using the odd and even selection could put some bias in the or could put some selectivity for the surgeon who are treating the cases. The second thing is the surgeon experience. In this study, we saw about 60 patients in the open reduction group had another surgery for removing painful hardware, and in the arthrodesis group they are only four patients. But the author didn't mention why we have 16 patients in the open reduction group for removing painful hardware, while we have could it be related to experience of the surgeon or not? It's not mentioned in the article. The third thing is the presence of comorbidity in the patient. The author put exclusion criteria only diabetes and peripheral vascular disease. But we also have another comorbidity could affect the healing of soft tissue, like patient using steroids and patient having cancers or using chemotherapy or radiotherapy. He didn't mention in this article. The last thing is the return to sporting activity. There is another review study in 2007 published in I think in Bone Orthopaedic Journal, mentioned that the return to sporting activity is better in patient treated with open reduction and internal fixation. But in this study, the author or the results show that the return to sporting activity is better in the arthrodesis group. The last thing I would mention about this study is the way of judgment, the way of assessment of the cases post-operatively. The way of assessment in these cases is almost always a subjective way, by using questionnaire and using visual analog scale. All these parameters are subjective, not objective. I think it will affect the the efficacy of this study. That's all.
Yeah, those are excellent points. I think you bring up a lot of the controversies for why, this is still not a decided topic, at least from what I understand. Dr. Bouila, your hand is raised. Did you have a comment to make based on what Dr. Sanad said?
Yeah, Dr. Khan. Thank you, Dr. Ali and Dr. Sanad, about this presentation. Actually, from experience, I faced many cases less frank fractures, but in general, I didn't use the open technique, but most of them I use the closed technique. Sometimes the cannulated screws and key wires. And also we found some cases missing because the patient, they come with polytrauma. We concentrate on long bone like femur, tibia, and later after we patient resuscitation and patient discharged, for example, and come to OPD clinic. So we found this also missed fractures. So in this case also, my experience mostly few years, but I never try open fractures, but mostly by closed fractures. Thank you.
Thank you. Well, we have a couple of faculty from the US on here who can maybe comment as to how they treat it in their hands. Dr. Blumen and Dr. Bonnie Chen, I invite you guys if you have any comments. Do you want to say anything about this?
Yeah, thanks very much, Karen. I think that this is, as you said, still undecided, and it's very interesting because from a base standpoint, I think we all want to preserve joints if at all possible. On the other hand, these joints have very, very small amounts of motion, and I think from studies as well as our own experiences, we've all had patients where fusions of these joints have produced very, very good results. And there's one of the studies that I think is important to think about is just how much cartilage is taken away by an ORIF, and this cartilage obviously does not come back. And some of the studies have shown that not an insignificant amount of cartilage is removed by ORIF, and so that may argue for fusion, and also, of course, the need for screw removal later on needs to be taken into account. And I wish I could tell you that I have a very well-formed algorithm that I use, but it's still very much, I think, subjective in my practice. And I look at things like the athletic activity of the individual and whether or not there's diabetes or smoking present in terms of whether I will attempt a fusion or not. So I don't know, Bonnie, can you help me with this? What are your thoughts?
Well, Bonnie gets her mic on, maybe John can comment.
Yeah, I think this is a very interesting article. There's a funny article that people call the parachute study, and it was published in the British Medical Journal. And for people who haven't read it, it's a very fun read because basically it's a little bit of a joke, but what this article is about. It's written as a scientific article, but it says that because we do not have a randomized prospective study showing the efficacy of parachutes, that we should really question whether parachutes are effective or not. Okay, and so you can see that it's a joke on how much we put weight on level 1 evidence. So for ligamentous Lisfranc injuries, we do have a level 1 study. But I think that one of the things that's important for the trainees in particular to understand is that for non-elective conditions in orthopedics, for trauma fracture patients, you really need to do the best surgery that you can do in your hands. So if you are less comfortable doing a fusion, you should do the best ORIF you can do. When I take trauma call and I have a patient who has a femoral neck fracture and arthritis, you know, the literature may support that that patient would do better with a total hip replacement instead of a hemiarthroplasty. But can I do a total hip replacement at all now? No. So that patient in my hands, despite the literature, is going to get a hemiarthroplasty. So I just like to emphasize that despite the fact that we do have this level 1 study suggesting arthrodesis is better, do the best surgery that you can do in your hands.
That's a great point, Dr. Kwon. Thank you for that. So for the purposes of time, we only have about 10 minutes of Journal Club left. So I'd like to turn it back over to the presenters for the last article on ORIF versus primary fusion for the type 4 calcaneus fractures. So go ahead, Dr. Ahmed and Dr. Khaled, if you guys are available, please.
I'm available.
Ahmed Al-Hajjaji. Dr. Ahmed Al-Hajjaji, are you there?
Yes, doctor.
Yes, you can start. You can start.
Okay. I will talk about open reduction and internal fixation compared with open reduction and primary failure arthrodesis for treatment of Sandra's type for calcaneal fracture. Okay.
Go ahead.
The calcaneus is the most commonly fractured tarsal bone and account of approximately 2% of all fractures. The mechanism of injury and pathoanatomy has been studied in great detail. Most fractures of the calcaneal are intra-articular with involvement of subtalar joint. And the calcaneus point joint in up to 75% of cases. The change in lifestyle because of residual pain and stiffness can cause significant socioeconomic hardship for these otherwise individuals and maybe have associated public cost. Okay. The literature of management of displaced intra-articular calcaneus fracture is confusing. The pendulum has swung from non-operative treatment to open reduction and internal fixation. All theory has suggested that delayed primary fusion was satisfactory for severe intra-articular calcaneal fracture. The early specimen about operative reduction of these intra-articular fracture began with the inability to predictably with good result and the high rate of complication associated with surgery. Also, retrospective cohort study and randomized controlled trial failed to show a significant difference between the operative and non-operative treatment. Large prospective randomization multi-center trial considered by the Canadian Orthopaedic Trauma associated with 559 enrolling patients has shown better functional outcome and patients satisfied in an operatively treatment group, okay, after excluding worker compensation for patient. Okay, despite carefully planned open reduction and near anatomical reconstruction, this is a group of patients who may proceed the painful subtalar arthritis and need delay subtalar fusion. Okay, it has been shown by various investigators that the prevalence of poor result after open reduction and internal fixation increase the severity of comminution displacement. Sandra's type for fracture with at least 3 fracture line across the posterior subtalar and have done poorly with both non-operative and operative management. In large Canadian prospective study. Please 1 minute.
Yeah, we can hear you again.
Have done poorly with both non-operative and operative management. In the large Canadian prospective study, it has shown that 47% of the fusion group had
Dr. El Hajeji, we can't hear you anymore.
Shall I step in and summarize from?
Please do. Yeah, give us your takeaway from this article.
More likely to go on
he's back.
Fusion. What, Doctor?
You carry on.
Thank you very much. Thank you, Dr. Ahmed. You do a good job. Thank you.
Okay, thank you, Dr.
Dr. Khalid, the stage is yours.
Thank you. Thanks everyone for the invite and for taking part in this interesting meeting. Now, I'd just like to summarize a few points about this paper, and must confess, I read it very late. But what I can say about this paper, this seems to be Mr. Buckley's, Dr. Buckley's interest in a calcaneum fracture. And the Canadians seem to have an attraction to a calcaneum fracture. And this is another evidence that we have struggled to answer, and another question we struggle to answer. What is the best treatment for a type 4 Sanders fracture when it comes to decision making? The paper actually tried to answer this question: is ORF, or open reduction talar fixation, versus open reduction talar fixation with subtalar fusion is better or superior? And the question was quite difficult to answer for many reasons. They looked at the 31 patients, the 33 fractures. It's one patient had bilateral, and they managed to compare the group with some variables in the group between the genders and the age. The majority were male, and we know from Richard Buckley's paper before, female do better, but that's another variable that they looked at. And also they follow them for 2 years with 6 weeks, 3 months, 6 months, and 12 months, and 24 months, radiologically and clinically. They've carried out the same surgery with open reduction talar fixation, same position, with a distraction fusion. When it comes to fusion, they use the iliac crest fusion, and they didn't look at the comorbidity that caused by the iliac crest as well. But it's a small size paper, it's a small sample, it's a small power. They admitted that in the conclusion. But the question they're trying to answer, whether this is, what is the better treatment for this? And we all know, we really touched on the previous paper, it's a difficult fracture, it's a severe fracture with a comorbidity, and other health variable need to be considered as well, going back to Mr. Buckley multi-center paper in the past 2002. But it's a prospective study, it's a multi-center study, so it carries some weight and has a level 2, but still the paper failed to show any superior option compared to with what comes to RF versus RF plus subtalar fusion. They use the validated measures to measure the outcome. 4 of them, particularly the short form is 36, a new version, and they use the American Orthopaedic Foot and Ankle Society, which is again another validated tool. But it's first paper that actually looked at this issue, and it's credit to them. They tried to answer the question. It's a difficult problem. It's a difficult one to answer, but they had to go. But I think that's all I can say. I'm not sure I summarized it well, or
no, that was excellent, Dr. Anaiba. Do you mind commenting, how do you take care of these patients with very smashed calcaneus fractures in your practice? Or did this paper change your perspective on that in any way?
I think they actually touch on looking at individual patients. We know from Mr. Buckley's paper, Dr. Buckley's paper in the past, that there's so many variables when it comes to intra-articular fractures. The female, younger female with no working compensation, they do better. But they haven't answered how many of those type 4 Sanders, they ended up having a subtalar fusion. So we don't know how many of those. They say here 5 to 10% in this paper. But then again, I mean, for us, it's individual patients. There's so many factors, a complex fracture, they have a poor outcome, they have generally a poor health outcome with these fractures. But this individual, if it's an isolated type 4 fracture that is young, fit, healthy person, non-smoker, with certain jobs, then I still believe personally surgery is superior to non-operative treatment.
And how do you typically approach them? If you don't mind me asking and mixing in the topics from the previous paper, do you do an extensile lateral, or do you do?
Yes, we do all them open. We use an extensile lateral. We use a soft tissue flap as well, a full flap, and it is normally some of them they open median lateral to ensure there's anatomical reduction. It's all about restoring anatomical reduction. We use as they said in the paper, they use the K-wire fix to mobilize a fragment and reduce anatomically, and then use all this fancy plates nowadays in the lateral approach.
Yeah, all right. Dr. Gonzalo Bastias, we have you on the line. Would you like to make a comment? I know that you are our expert on Liz Frank injuries, but I'm sure you take care of many patients with calcaneus fractures. In Chile, in your hands, who are the patients that you are fusing rather than fixing?
Hi, everyone. Hi, yeah.
Gonzalo, I don't think we can hear you.
Sorry, guys. Can you hear me now?
Yeah, we can hear you. Go ahead.
Well, actually, we're just in this at this time we're doing most of our calcaneal fractures with the minimally invasive approach. Usually here in Chile, they always told you, like, when you're a resident, that you have to do like 14 or 50 extensile approach before coming into the minimally invasive alternative. But I think things have just changed. Probably our residents now are being more exposed to the minimally invasive techniques. So I think this is something that's changing. I think in the last 5 or 10 years, and sorry guys, and probably this will continue to change. I don't know if the extensile approach. There are some fractures that I think you must need some of those.
Well, Gonzalo, what about fusion? Are you fusing your calcaneuses primarily?
Actually, no. I think there's very little space for that. I think it's better for us to try to reduce this and try to get it as better as we can, and see if in a second time we can go back and do the fusion if needed. But yes, I think it's for when you do a primary fusion, both in the subtalar joint in case of calcaneal fractures or penile fractures in cases that are destroyed, I think it's very difficult for them to fuse. It's not the optimal environment, and sometimes you must think better to try to get a hold on this and try to make it as good as possible, and then if it's necessary, do as a secondary procedure, do the fusion.
That's a great point. Dr. Kwan, would you mind giving us your sort of a final thought here about calcaneus fractures, when you would fuse them, in your practice, when are you using all these different tools in your, in your toolkit?
Yeah, I'm challenged by this article. My thoughts are that for the bad Sanders 4s in particular, they do better with ORIF and primary subtalar fusion. My limited anecdotal experience is that they do better, but we're tasked to practice evidence-based medicine, and we don't have evidence to show that this is the treatment we should be offering. So I am probably like the rest of the group really challenged on how to treat these patients. In my experience, I have found that when you do fusion, it is a reasonable biologic environment, and I've been lucky probably to get these patients to fuse. In my hands, the patients who definitely will get OREF and primary subtalar fusion are the patient who has a calcaneus fracture displaced that's missed. And for one reason or another, whether they're neuropathic or they're just tough patients, that they walk on it. And then you discover they've been walking on it for a week or so, and then you discover the fracture. I found that those are very difficult to reconstruct the fracture fragment. So that's the patient that will definitely get OREF and primary subtalar fusion.
Thank you.
Sorry, if I may add a point here. I think the paper actually showed that the OREF with subtalar fusion, it showed on the long term and with economic reasons as well, the patient will end up having one surgery and less complication, and with a slightly better SFA 36. So it does show that superior fusion is slightly better than primary RF on the long term, with patient likely to have one surgery. So you know, here you go. You've got something in your favor.
Interesting. Dr. Gwilla, you have your hand up. Did you want to make a comment?
Yeah, thank you. Just I want to ask about what is the difference between primary and secondary subtalar arthrodesis in open fracture cases from experience? Is there any difference between primary and secondary in the longer run?
Well, I think Dr. Anaiwa's point there was that you're saving a surgery. And so there's a cost benefit to doing primary versus secondary fusion. And also the risk of wound complications supposedly is less if you're doing a primary one. But I'd be interested to hear Dr. Kwan and Dr. Blumen, if that's your experience. I mean, Dr. Kwan, you were maybe suggesting that, and actually Gonzalo, Dr. Bastias, you were suggesting that perhaps putting together a fracture, fixing it primarily, and then if there's a need for a fusion later, you don't really lose anything by going back. Is that your experience? How do you feel about that? Gonzalo, maybe you can start.
Yeah, I remember like looking at this like comparative studies between fusions, subtalar fusions made on a primary basis and on a fracture environment. I don't have the data now on me, but I remember I just checked it up like 5 or 6 years ago, and there was a slight more chances that your fusion won't fuse in cases where it was on a primary setting. So I don't know how things are now in that. I haven't checked it out lately, but I had just bad luck. I have like 2 or 3 cases that I have to go back in to put some autograft bone to get this fuse after all. And yeah, I think it's great that we can do some things in one surgery. But sometimes you don't get lucky on that, and you have to go back. I haven't checked this nowadays, but yeah, I think it's my experience is that it's difficult something to get fused on a trauma setting. But yeah, it can be only my experience in that case.
Thanks, Gonzalo. John, go ahead.
Yeah, I just want to make a final point. You know, as surgeons, we all work on our feet, and many of us like to work with our hands and do manual labor as well. But most of us are not manual laborers. So I guess one question to ask yourself is, with everything that we know about calcaneus fractures, if you had a Sanders 4, would you want to have an OREF and a primary subtalar fusion, or just an OREF? And even though the literature may argue differently, I would want an OREF and a primary subtalar fusion. As we know, the subtalar fusion, if done correctly and positioned well, is very well tolerated in the long term. So, you know, just a different way to think about it.
That's a great point.
Yeah, I agree. I agree totally with Dr. Kohn.
All right, well, thank you all. That was a really lively Journal Club discussion, way beyond my expectation. Thank you all so much for that. Dr. Ayman, I think maybe we'll take a 5-minute break here for prayers, and then we can come back and continue with the case presentations. Does that sound all right?
Yes, thank you, doctor, because we have time for Asr prayers. Just we will take only 5 minutes and then we come back to the case discussion.
No problem. So I'm going to just pause the recording and then we can come back in 5 minutes.
Yes, thank you.
Thanks.
Thank you.
So I'll come back. All right, so now let's begin the case presentations. We'll begin with the case by Dr. John Kwan. So please go ahead.
Okay. Are you able to see my title slide here?
Yep, we can see it.
Great. Okay, so this is a 50-year-old healthy male. He works as a police officer in a local police department, and he was in a car accident, and he sustained this fracture. So this is clearly a Hawkins 4 fracture dislocation. And as is typical, these are open injuries. And so in the photograph, the foot is distal, and you can see that it's a near transverse laceration laterally. The resident is pointing out the pathology, and we appreciate that. And as we teach our residents, this was quickly irrigated. The talus was reduced in the emergency department. You can see some fragments in the back there, and a CT scan was performed. So typically what we will do is take the patient emergently for irrigation and debridement and placement of an external fixator. And I think that many would do so.
Excuse me, Dr. Sean. I
Yes.
think something in the screen, we cannot see all the slide. Is it clear for you? All the slide?
Yeah, it's clear for me.
I can see it as well.
Yes.
Okay.
Dr.
Sorry.
Ayman, are you seeing a picture of a CT scan?
Yeah.
Yes, now I see, but however, I think, okay, now it's okay. Thank you.
Okay. So this was taken by one of my trauma colleagues for irrigation debridement. They were able to reduce the posterior talar body. And given the fact that they were able to reduce it, they went ahead and put 2 screws in here. I was asked to resume care at this point, and I wanted to get a CT scan because I wasn't sure if the talar body was reduced. And so this is what the CT scan looks like. The patient is about 6 days out, healthy. And so what would the group do at this point? Obviously, there's some different options here, but just curious to know what any of the US or Libyan or Chilean colleagues would do.
I can start if that's okay.
Yeah, of course. Go ahead.
So John, I think that you know, the good news is that the joint is better reduced than initially, and hopefully that bodes well for the the retrograde blood supply of the talus. But I think obviously that the malreduction is going to be causing problems in the future for this patient and needs to be revised. I think that with the external fixator on, you are probably neutralizing some pathologic joint forces, and so you could delay it. until the soft tissues calm down, and that may be a consideration. But at some point before healing advances too much, you want to revise this.
Can I also say something?
Yes, please.
I agree with Eric. Just my interesting point here I want to ask is, what made you get a CT scan? Because this is just a good shot for finding out what's going on right now. And also, what is the soft tissue status now 6 days down the line? Didn't appear to me in the first picture that was badly reduced, but it is now, and it clearly needs more work doing. But that's a good shot. That looks okay to me.
Yes. So I had some concerns looking at that AP fluoro. I did not include all the images, but you know, especially for the trainees, when the subtalar joint isn't well aligned and the talonavicular joint is not well aligned, that is a clear indication that you have a malunion. And Dr. Khalid, I did not include those pictures, but that was my concern for getting the CT scan. And in terms of the soft tissues, at this point, he's about a week out. The lateral side is provisionally closed. There's no evidence of infection. He has the amount of swelling you would expect. Would anybody consider, given what we know about osteonecrosis and post-traumatic arthritis, just leaving it? Leaving it and seeing how he does and considering a fusion later on. Would that be an appropriate option?
I think it depends on how the soft tissue will evolve during these days. I had some cases like this that probably with a lot of skin necrosis and going the wrong way, and yeah, I had 1 or 2 cases in which I let this go and talk to the patient and tell them that probably the safest for its soft tissues is try to think in an arthrodesis on an early base. We have a similar case in our hospital, and there was a big discussion because some residents also put some screws in the first surgery, and some of the older staff were like really angry at them because they say you don't have to do this, you just do some K-words. But I think, like Dr. Blumen said, I think that the objective of reducing this at least and like a near reduction, I think it's very useful in these cases. I don't think I don't know what you think, Dr. Kohn, in terms of going back and say it was okay to put the screws on, just use wires. What would you say about that?
Yeah, I think I agree with you. You know, I think these screws were placed because the surgeon was happy with their reduction and thought that it would benefit the patient to stabilize that posterior fragment. But in my mind, I think that the goal of external fixation is to grossly align the extremity, protect the soft tissues, restore neurovascular status, and to leave any definitive fixation to the surgeon who will likely be treating it. And so I'll move along with this case, but the toughest part of this case was getting those headlift screws out that were put in. And so looking at this,
obviously,
I decided to do a medial malleolar osteotomy. And so you can see we're marking out the osteotomy. To the trainees on the call, it is helpful to pre-template and drill your screw holes provisionally, so that when you reduce your medial malleolar osteotomy, you can get anatomic reduction of the medial malleolus with no translation. So I'm doing that in the middle picture. We went ahead and fixed the talus. One interesting thing is you do not see the medial malleolus in this fluoroscan. Usually you see it flip down, and the deltoid was completely avulsed off the fragment, which certainly gave me some concerns for eventual healing. So we were able to go ahead and fix this. And I was reasonably happy with my reduction. You can see the subtalar joint is reduced, the talonavicular joint is reduced. I did put anchors into the medial malleolus to repair the deltoid ligament back to the medial malleolus in hopes of restoring the vascularity to that fragment. And this is the patient about 3 months out. And this is the postoperative CT scan. And you can see that he's really done reasonably well. In severe trauma cases like this, I will prophylactically and I will do a percutaneous tendicles lengthening because I think they get all stiff. But the story doesn't end there. He's about 8 months now and having more pain. And this is how he comes back to my office. Any thoughts from our colleagues what to do at this point? Simply watch it, some type of heel bone osteotomy, go to fusion. Thoughts, Dr. Farouk?
How's he clinically?
He's having pain. He's having pain, and he notices his varus deformity.
Okay, sorry.
Yeah. Yeah, just my concern is from the first slide, which I have seen, there is a comminution at the medial surface, the medial aspect of the talus. And I was willing to say for the medial osteotomy as the doctor's done, but I mean, in terms of fixation, these screws, I guess it could be, it's not enough. That's why we have got the deformity at the end, because maybe because of the medial or the varus malunion, or it could be because the fixation at the medial aspect is what it wasn't enough. And I guess if they have done the mini plate, is quite better. Maybe they got a result. In terms of deformity, I think I cannot even give you a clue whether it's the deformity because of stability or the type of fixation itself. But the medial surface of the talus, it should be fixed with mini plate, in my opinion. I don't know. Thanks.
I think it's a tough problem. It's a tough fracture. It's a multifragmentary comminution from day one. And I think whatever you do, you're not going to have a good outcome. But it is what it is now. And the question is probably what you're going to do. Is he still a police officer? I doubt it.
He is. He's not back at work. He's not back at work now. But at this point, he was having increasing pain, and he noticed his own deformity. What would you do, Dr. Khalid, at this point?
I get another CT. We had another CT. And also, I re-talked to him. This is an individual. This is a patient-surgeon discussion. I'll talk to him about, all the options, continuing pain, more conservative treatment, splinting, bracing, changing lifestyle, changing job. And then in the background, in the back of my mind, it will, with a fusion. So fusion will be your next move, but you just try to delay it and play it well and discuss it thoroughly with the patient.
Yeah, so just so we can move ahead and show some of the other great cases. I had a talk with him, and I decided to do a TTC arthrodesis. And my rationale was that, we know that the subtalar joint with talar neck fractures gets post-traumatic arthritis quite frequently. I was worried about his inherent vascularity of his talus. And so although I certainly don't like to sacrifice joints that I don't need to, I thought he was best served with a TTC. And so he had a TTC. He's doing well. I don't have it in this talk, but have a CT scan, and he's fused on both joints. I don't think he'll ever return as a police officer, but he's doing well.
Quick questions. How was it easy to take all these screws out?
It was actually easy because of this, his non-union of his medial malleolar osteotomy. Normally when I do a TTC, I'll do a fibulectomy and approach it laterally. But I decided to approach this medially. And so you can see that I just removed the medial malleolus, accessed it. And so I had direct access to all my little screws that I was able to remove. So.
And you just decorticated the joint, or you put a bone graft?
I decorticated. I do add bone graft and a separate sinus tarsi approach to debride the subtalar joint. I do think it's important to debride both joints and prepare both joints.
Good work. Good. Looks good.
Okay, thank you.
All right, thanks, Dr. Kwon. That was a great case, great discussion as well. So I guess I'd like to hand it over to, let's see, I think the next presentation should be on calcaneus fracture by Dr. Gwilla. Do you mind, Dr. Gwilla? Can you present yours? Would you like to share your slides, or should I share the slides for you?
Yes, Dr. Ali, yes. Okay.
All right, go ahead.
I don't have permission to share.
There you are. You should have permission now.
Okay. Yes.
All right, whenever you're ready, go ahead.
Okay. Thank you for all faculty to this meeting. It's nice to share our cases and our experience over the seas to see it is what's the best for our patient. Today we have a view of calcaneus fracture cases. I will present one case now. If the time is allowed, we will proceed to present 2 or 3 cases others. We will start by the first case. And the first case is a 47 years old gentleman, worker healthy, post RTA in April.
Sorry to interrupt, but we can't see your slides going forward. It's just we have this window saying start mirroring with Smart View.
Okay. I will. My slide is not clear.
It's not moving forward.
Not moving. Okay.
Would you like me to present? I can share the slides if you would like.
Yes. Okay.
All right.
Okay.
Go ahead.
Okay. Sustained, we stop in the history of present illness, post RTA in the April 2015. Sustained left ankle pain, swelling, deformity, and knee pain. On examination in our casualties, vital signs stable and Glasgow coma scale was full. ATLS protocol was proceeded. Local examination for the lower limb relief it's swollen and deformed left heel with tenderness. Distal neurovascular is intact. No sign of compartment syndrome for the foot. As we know, it is one of the big complication for the calcaneus fracture is the compartment syndrome. Investigation, routine investigation, X-ray for ankle, AB and lateral axial views, AB and lateral lumbosacral lesion as associated 10% for the lumbar spine injury, CT scan for the left ankle. This is the axial view and the lateral view for our patient. As we see, this is a calcaneus fracture, decrease Bohler angle and increase the angle of Gissen. And axial view.
Do you mind if I pause here and just make a comment? Dr. Kwon, are you still on the line?
Yes.
So one question that I think is important to cover is sort of what you can see on this X-ray. What are the structures that point out how bad this deformity is? So one is looking at the lateral aspect of the posterior facet, which I believe you can see here. Is that correct, Dr. Kwon?
Yeah, I think we can see on this lateral that it appears to be a tongue-type calcaneus fracture. If we were to draw out Bowler's angle, it would probably be 0, if not negative. I have found, and I think the literature supports this, that the angle of Gissane is maybe a little less important with decision making. But I think the key to look at this, especially looking at the CT scan, is to look to see where that lateral portion of the posterior facet is, because that's the key to our reduction in terms of getting it reduced to the anatomic angle of Gissane.
Right. And so this is the lateral aspect of the posterior facet that's supposed to be articulating here, right? So
Correct.
you see how this is being pushed down. That is the deformity that you see on this view. So just wanted to pause and point that out because I think it's an important point for the registrars. All right, please go ahead. I'm sorry to interrupt. Dr. Ali, are you there to continue?
Okay. This is the CT scan. Sagittal view and this sagittal view. As you see, it is involved in the subtalar joint and depression of calcaneus with it. Decrease the height and increase the width. This is the coronal CT scan. That's a view we can decide the Sanders classification from this view. Mostly type 3 Sanders classification. So our diagnosis is closed fracture left calcaneus Sanders type 3. Next step, so we will do primary Jones bandage for ankle. Sorry, it's not bilateral, it's left ankle. Wrist mobilization, compression, and elevation. Follow up weekly to observe a wrinkle sign, dorsiflexion. Surgical intervention, once soft tissue condition allowed. This is the skin condition after 2 weeks. As we see the obvious positive wrinkle sign. The best approach, I mean, when I bought this question, what's the best approach? As you see, is the sinus tarsi approach or the lateral extensile approach. In our center, we more experience with the lateral extensile approach in shape. In this patient, we proceed with the LCB 3.5 mm calcaneus plate via lateral extensile approach. This is the intraoperative beginning of our approach, and landmark L-shaped from the horizontal line and vertical line behind the fibula and in front of the Achilles tendon, and the horizontal line at the area junction between different color. This is after reduction, and the flap was done single flap.
If I can make a comment here, you know, I think your incision placement is excellent, and so, you know, your horizontal limb is on the junction of the glabrous non-glabrous skin, but probably more importantly, your vertical limb is just in front of the Achilles tendon. You know, I think you know, if you read certain textbooks, they still recommend putting that vertical limb halfway between the fibula and the Achilles, so more anteriorly. And Borelli and other people have shown that you're very likely to violate the lateral calcaneal artery. which may be contributing to wound problems. So I very much like how your vertical limb is a little bit more posterior.
Okay. Thank you. Next slide, please. This is the post-operative. As you see, the post-operative X-ray, and it's all the X-ray. We sorry for the bad quality of our X-ray. We try to address the better in the next time, inshallah.
No worries.
Okay. This is the skin condition and soft tissue condition after surgery by 3 weeks or 3 weeks or less than 3 weeks. Trusting on the one side, everything was okay. This is the last case from our tree in the culture. We have 2 cases. If we can present 2 cases, we can same presentation. If the one case is okay, okay.
Well, let's just for the interest of time, because I also want to get to the other cases.
Okay,
let's maybe just take a moment here to go over, what were the challenges for the reduction here? The patient obviously has done quite well, but if the patient hadn't done well, if there had been wound complications, if there had been subtalar arthritis, what were the things that were going through your mind in terms of managing the complications from this if they were to arise? And Dr. Kwan, feel free to jump in and comment as we go.
Is the question for Muhammad Guela or for everyone?
For anybody.
Yeah. Muhammad Guela. Muhammad.
Yeah. Regarding the post-operative status, the patient is, was well, and even though some faces some skin condition is issues, but treated by antibiotics, and he doing well and started returning to the job. And actually, because he's Egyptian, not from Libya, and traveled to his home country, but that's why we lost the follow-up with the patient. But during the time when he was being in Libya, he's doing well, and he encouraged himself to start return to his job. And in terms of subtalar arthritis, we try to address all the fractures intraoperative. And for us, because it was done in 2015, almost 6 years now, we lost most of the data from the patient. But we have another case, if possible, we try to present it. We have 3 years follow-up. It was by letter after this slide. Yeah, after this slide. Go ahead, more. Yeah, this is actually 21 years old gentleman. He actually Libyan medical student, fall from height. It was May 2018. Bilateral ankle and calcaneal fractures. AR done already. Resuscitated in AR. And see next slide. Yeah, other slide. All the investigation and diagnosed that he has a bilateral calcaneus fracture, calcaneus with the L2 compressed fracture. This is conservative at that time. The steps we do for soft tissue condition, primary joints bandage, follow up to observe the skin and surgical intervention. Next slide. We did 2 procedures at the same time. For one side, we did LCB, and another side, just we reduced by close reduction technique by acyclic laparoscopy technique for the other side. So we see the X-ray. Next slide. This is the intraoperative for the right side, for the left side. Next slide, please. Post-operative 3 years follow-up. This is actually 2 weeks ago. He's doing well. Active, currently in internship, practicing the medical career. And this is the left side. And the next slide. This is the right side. This is done by acyclic laparoscopy technique. And next slide, please. This is the axial view. We see the varus or valgus deviation. I bet this is virus. But so far, there's no more complication. He's well. Next slide, please. And this is condition after taken last week. Right side where we did the percutaneous technique, and the left side. Next slide, please. The scar side is so far is no some skin contractures, but in general it's healed completely because even though education is very important to manage this operative cases because he's a medical student, close follow-up and always on regular follow-up with us, even though almost 3 years now. Next slide. Yeah, this is we took photo. Actually, it's no video, just took photo when he's standing. Yeah. Next slide. This is the standing from posterior view. It is widening some heel, but actually this is going to, we explain to the patient from before the surgery, he will face some complication, maybe late. Okay, next slide. This is actually other case number 3. This we did also percutaneous fixation by screw fixation. This is considered as a tongue tie. Next. Yeah. The case number 5. This is the right side also. 2 case. Yeah, this is a fixation interoperative view. Next slide. We face some wound adhesions, but treated by antibiotics and regular follow-up, and the patient will. I mean, we know it takes time, maybe 1 month, 2 months, but doing his activities, returning to the job. And so far, that's what we have in our experience. Most for cases, we're so very sorry because we don't have data. Yeah, we know it's our hospitals. We didn't concentrate about the record, but in future we try to manage ourselves to present better photos and views, and all data will be available for discussion. Okay, thank you very much.
Thank you. Those were all excellent cases. Dr. Bastias, would you like to comment on sort of how you manage these calcaneus fractures and anything that you would take away from these cases presented by Dr. Guilla?
Yeah, I think there are excellent cases with excellent solution, and execution of fixation must be very thought in terms of every screw must have an intention. You know what I mean? Sometimes you want to just throw a lot of screws on your plate and try to make it fix, but I think you have to get your CT scan, think about how are you going to fix this, and think that every screw must have their own intention. I think that in these cases, even though it's very common to have some kind of soft tissue injuries, it's very thoughtful to talk before with the patient and tell them that mostly it's probable that something may come along, and it's always better to overreact on these complications that to have a passive role. I've always been very aggressive with my skin soft tissue complications, and I think that's a good thing. I think my best advice would be that I think that probably when you are too passive with this, probably when you can have it blown on your face.
So Gonzalo and Dr. Guilla, maybe you can tell us a little bit about how you manage wound dehiscence in your extensile lateral approach. So I'll give you an example. You have a patient, smoker perhaps, had an extensile lateral approach, comes back to see you, 4 weeks after their injury, and they seem to have a small dehiscence with some drainage, no obvious purulence. How are you thinking about that? Are you taking that patient back to the operating room? Are you cast immobilizing them? Or how are you treating these wound complications in your practice?
Okay, thank you, Dr. Karan, about this question. Initially, as we actually, as an orthopedic surgeon, we know how to deal about all the open fractures and infection post-operative. First of all, we need to confirm diagnose. Is it a surgical site infection? Is it superficial or deep infection first? And if the patient, come to you after 2 weeks or 4 weeks post-operative, and he's a smoker, actually before we start the surgery, we try to explain to the patient the risk of smoking for the surgery, and try to encourage him to quit or reduce the doses of smoking. The first important thing before when we take the informed consent, and we explain all the communications from A to Z to the patient. After we get the informed consent, and we go ahead and we give prophylactic antibiotics for these cases, and then, as we mentioned, if something happened subsequently later on, we manage. If it's like wound healing, we just do oral antibiotics, and we try to do wound dressing daily by normal saline. If something come out, we take swab, and we treat according to the swab and antibiotics. In cases, but for me, because learning curve, short time experience, we don't have, for example, we deal with all trauma, but sometimes most of the cases after stabilization, they transfer to other hospital. For all the cases I have done, I never seen anyone, this is only that case that I show to you now. But then after stabilize, he's the wound healed completely.
Dr. Bastias, any comments on all that? Like how do you said that you're very aggressive about dealing with
I totally agree. I think that one thing that must be certain is that when you have like skin necrosis, like I think that's the main red flag for me to get on the OR and get all that out. I think that when you have like the triangle that conforms between both limbs of the approach, and you have like really early skin necrosis, probably this patient must be taken to the OR and be debrided. And thoughtfully, in cases when you have you can have a plastic surgeon that can make like a really early cover up. I think it's better to be done in that way. One thing that it's important that calcaneus usually heals pretty fast. So sometimes if this is like delayed wound problems, like at 8 or 12 weeks, I think sometimes it's better to take all out, because probably your bone is healed already, and that would totally can help you out with the control of the infection in cases that it is. I think that the worst case scenario of having a calcaneal osteomyelitis, I think it's something that you have to see with a lot of respect. So probably you don't want to get over there. So when you see a skin necrosis, probably it's time to get that patient into the OR.
What did you say you're doing with the hardware in those cases?
Well, in cases that are less than a month or 6 weeks, I try to hold at least whatever I can. I usually put 1 or 2 screws out of the plates. So in case I have to take the plates out, not everything like go down. So sometimes I take my plates early in case of early infection. So 1 or 2. But if in cases of delayed skin problems, I just take everything out. Like you have like more than 6 weeks.
Okay. Dr. Sanad, I see your hand is up. Do you have a comment to make?
Yes, I have a question for Dr. Mohammed Guela about the case of bilateral calcaneus. Could you please, Dr. Kiran, show the slide of the bilateral calcaneus?
Yeah, I believe this is that case.
No, the clinical photo.
This one?
Yes, this one. I think in this case we have cavus foot. Is it a result of complication as a result of hind foot varus? And does the patient has any complaint about it? And if he has.
Dr. Guilla, go ahead.
Yeah, I think this one, so sorry, because a very bad photo, when you take over stretched the photo, but clinically is no any Kevipar's deformity. You see?
Yes, in the left leg, there is a little bit.
Yes, valgus, yeah, if you're right. Maybe a view, but it's not negligible, yeah, on the left side. But even though the patient doesn't complain any pain, as I mentioned to you.
And Dr. Guilla, can you also comment on the SS Lopresti technique? Can you describe that for all of our trainees on the phone?
Yeah, actually, I'm sorry that I told you I don't have intraoperative video for that, but the aim to try to address the articular surface. What we do, under image intensifier, II, we need assistant actually. I try to reduce the fracture under image intensifier. Then after we put the K wire to a constant fragment, the big one would be piece, because it's going to me, and then we use and elevate the depressed fragment from posterior, and we keep it in place after take X-rays from AB lateral axial view and also AP view, and then we use the back slab cast, and we keep the leg in the cast for 6 weeks and the regular follow-up. So this is actual technique. Sorry, I don't have any X-ray before and post immediate post surgery. But this is 3 X-ray right side 3 weeks ago taken last week. Sorry, this one last week from our patient. As it mentioned to you, because we lost all the data, but this one medical student, it's easy to contact him, and he's the doctor now, and he's happy to share the photos and to others to see the outcome of our center.
Well, that's great. Thank you for sharing these cases. So
thank you very much.
I think for the purposes of just moving along, why don't we move on to the next case, if that's okay with everybody. So the next case that I have here would be from Dr. Walaika. Would you like to present?
Dr. Ziad?
Yes,
are you
I'm
ready?
here. Yes, ready.
Okay. Can you share your slides?
Go ahead, or I can share yours, whatever you prefer, Dr. Zayad.
Okay.
Great.
Okay, I'm sorry, give me a minute.
Sure.
So. Okay, is it clear for you? Dr. Kiran?
We don't see the slides, we just see a folder.
Now?
Busy folder.
It's still just your folder, no slides.
Dr. Ziad, before you are good, you share the presentation, but I think you share now the folder. Go
yes,
back.
Now I share the presentation. It is clear for you, not still?
No, it's
no,
not
we
I'm going to go ahead and do it from my screen.
Yes, now.
Okay, I think.
Dr. Zayad, go ahead.
Yes, okay, good.
Okay, thank you so much, Dr. Kiran, Dr. Ayman. I will talk about foot fracture. This case, our case of visitation. Now, from history, 60 years old diabetic male patients. He has had history of direct trauma by heavy objects on the dorsum of the left foot. It is voice clear for you?
Yes.
Yes, yes, good.
Clinical examination, there is a wound on the dorsum of the left foot on the lateral aspect, swelling, patient unable to bear weight, open fracture, grade 2, no new vascular injury, pulse, peripheral pulse is palpable. This X-rays pre-presentation at the time of presentation. Unfortunately, there is no clinical picture of the wound at the time of the presentation, but only the X-rays. But I will show you the wound after closure and debridement. Okay, is this clear for you?
Yeah, maybe we can pause
Okay.
here.
Okay, this is open fracture on the doors of the left foot on the lateral aspect. Now on X-ray IB lateral and oblique view, we show there is fracture. This is a type of rare fracture of the isolated medial cuneiform, comminuted fracture dislocation on the oblique lateral view. This in IB view, you show comminuted fracture dislocation in the medial cuneiform. This is not purely less frank fracture dislocation because the space between the first and second ray, it's not too much widening. The second base of the second metatarsal and the middle cuneiform, as you know, is the key stone of the instability of the tarsometatarsal joints. So as we did for him, CT scan for the foot, show there's here fracture dislocation of the medial cuneiform. Also here, I'm sorry, on X-ray, if you see here, there is a small associated fracture on the navicular on the medial side. This is
this one?
Fragment, small fragment in place. Okay. CT scan as you see here. Okay. Now, what's the options for treatment in such a case?
So, Dr. Zayad, why don't we pause there and ask some of our international colleagues to comment here on Dr. Bastias and Dr. Chen, if you're on the line. What are you thinking when you look at this?
Well, yeah, I think that the patient, well, this is a high energy fracture, even though it's a direct blown trauma to the foot. Yeah, I'm thinking that probably most of those joint surfaces are like really comminuted. So probably the length of the medial column has to be regained. That's my first thought. And yeah, I think there are multiple ways to do that, especially in a diabetic patient. But yeah, I think the objective of whatever we do in this patient is try to get that length and give stability to the medial column.
And so how would you go about doing that?
Well, I would do like probably in a normal patient, I would do like open reduction and internal fixation with probably transarticular plates and plating and get like a rigid medial column. This can be assisted with an external fixation also. In case of a diabetic patient, if this is like a complicated diabetic patient, probably will try to do something more percutaneously. But yeah, I think my common approach would be like open this up and put like rigid plating.
Are you going to do anything about the navicular?
Yeah, probably throwing some screws out there at it and try to gain function that, because probably that talonavicular joint, if it's not left anatomical, probably will give us problems not far ahead.
All right. And then for your medial column plates, are you going from the cuneiform distal only? Are you going to try to mobilize between the
probably you probably will have to do some like subreconstruct in this kind of patient, like passing some healthy joints, but yeah, I will go long from the metatarsal even to the tails.
All right, Dr. Zayed, what did you think?
Yes, I'm did for this patient. We did for him just under spinal anesthesia and complete septic condition. The patient's supine position fixed by mini external fixation, Hoffman type 2. As the distractor technique, just distractor exactly with cross K-waves. A wound debridement, approximation of wound, exercise all the vital. This is open fracture grade 2. Okay. Now we will show you the technique and what I will do as available facility. Okay, here in X-rays, B letter B, we did for him mini external fixator, distal, chance bends in the first metatarsal bone, and the proximal two chance bends for talus in the talus. Okay, just distraction, reduce the fracture, and two crossing K-wire, one from the base of the first metatarsal to the third, and the second one from the medial cuneiform to the second metatarsal. Okay, this is the immediately post fixation, AB, lateral and oblique views. Okay. This 2 weeks post fixation, this is the wound that I need to show for you. Necrotic. Okay, there's a necrosis here. Okay, this I'm sorry, there's some gapping. Excuse me. Well, if you can return to this picture of clinical picture, yes. In this case, in this picture, 2 weeks immediately post fixation. What to do for this patient? Diabetic, necrotic, still there is edema. We did for him second debridement, remove all necrotic and this black discoloration. Okay, would go to dressing and covered by antibiotic. At 2 months follow-up of the patients, clinically, patient healed clinically and radiologically with active range of motion, okay, passive, mild degree of dorsiflexion and plantar flexion, no pain, no tenderness at the fracture site here, exactly, okay. Post-operative follow-up, the patient show good alignment of the fracture post-operatively, allowed non-weight bearing from second day post-operative. The structure and K-wire removed after 8 weeks of the operation. The active range of motion started at the same time. The patient was mobilized with weight bearing as tolerated and started full weight bearing at 6 months following surgery. At the final follow-up, 12 months after injury, the patient had painless foot and normal range of motion and good walking. I will show you a video in the patient walking very well. This at 6 months follow-up, good healing of the wound, good dorsiflexion and plantar flexion, good range of motion. Okay, no pain, no tenderness. There is a video, but I don't know, maybe take long time for download.
Yeah, I think it might be challenging. Well, that's fine. I think that's a fantastic case.
It's brilliant.
So, Dr. Vasquez, please go ahead.
Yeah, I think it's the approach here is brilliant. I think that probably like doing all minimally invasive and really get this fixed with the K-words and doing the distraction of the medial column to get everything like on place and avoiding like large exposure approaches. I think this is a really good case to get the example of how to approach diabetic patients with difficult fractures. I use a lot of external fixation in my cases, and I think this is great. I congratulate you for this. I think it's a really good approach that in cases
Thank
of
you
open,
so much.
yeah.
Well done, good case, Ziad. So sorry, I'm sorry, I jumped in without warning, but
Please do.
maybe a little excitement for Ziad. In hindsight, so what will have done anything different if we have more facility and more infrastructure? I know the situation is difficult there, but if you had more options, what would you have done?
For media uniform community fracture, I do for him, did for him many blades for restore the length of the fracture and the bone.
Yeah, I mean, as Dr. Gonzalez said, is reconstructing the rigid column is the principle of surgery, regardless how you do it. You've done it with a really limited facilities. You've done a fantastic job, but yeah, it's an intra-articular fracture, and the principle is the same: is to reduce the anatomical reduction and reconstruct the medial column. Well done, great stuff.
So,
thank you, sir.
Would you have opened this if you had the right facilities and the plates to do so?
On day one, yeah. Will you?
I don't know. With the soft tissue issues that we see later on, I wonder if maybe a percutaneous approach would have been better to begin with.
Yeah, I think with a diabetic soft tissue injury, I wouldn't rush to do it in a day one. I think the mini expects is a fantastic job to wait for things to settle down.
I think the best approach he did with the skin and diabetic with the facility.
Absolutely.
Good decision. Yes.
Well done.
Dr. Kiran, if you give me minutes.
Sure.
There is this type of fracture is a rare type, a rare injury, as you know. Medial cuneiform and intermediate cuneiform fracture dislocation. There is a paper published in India in 2016 regarding this type of injury. The team in India do for this type of fracture just distract like this technique, but without open reduction OF, not done or just for medial cuneiform we do for its mini screw, headless screw. This paper conclusion, this novel method of treatments, as the team in India published in this article. There is an article, but I'm not posted here in 2016.
Interesting. Have you ever tried anything like that in your practice?
Yes.
And
next case. Thank you so much.
What have been your results of doing that?
Yeah, thank you.
Okay, all right.
So
let's move on to the last case then. Dr. Bastias. Gonzalo, do you mind? Do you want to share your slides yourself, or would you like me to share your slides for you?
No, I can share it myself. You have to give me the authorization to it.
Yep. Okay, you should be able to share them now.
Good. There we go. So can you see my, can you see my slides?
Yes, perfectly.
Okay, I will go with the case. This is a 45-year-old male. He was at a pool party. He fall with forced plantar flexion on the pool stairs. Immediate dorsal pain and ecchymosis. And there was no plantar component on the ecchymosis. So this is our DR X-rays. We can see what this looked like for the emergency physician. He didn't see anything at all. So we, in this case, here's the lateral. So the art doctor established that there was no fracture, and he treated this like a midfoot sprain. So what was the plan in this case? I will go back to the X-rays. I don't know if anyone can jump in and try to get with this X-ray that are non-weight bearing X-rays. Can someone like spot something or get something about this?
Would anybody have noticed that this is an abnormal X-ray?
Yes, there's a space between the first and second metatarsals. Maybe ligamentous rupture of the Lis Frank injury.
Yeah, that
I mean.
get my attention also. Yeah.
Dr. Farouk, go ahead. You have your hand up. Dr. Farouk, are you there? All right, Gonzalo, go ahead, continue.
Okay, so in these cases, well, we have multiple options. Well, what would you do with this case? I put some 4 plans. One is get this man on a walker boot for 10 days with restricted weight bearing. Some other colleagues would argue that we need an MRI when in the outpatient counsel in 10 days. You can go with comparative weight bearing X-rays in 7 or 10 days, or just get this man a rigid sole shoe for 3 weeks. So in order of time, I think we'll go with the C. And in 10 days, the patient had some pain, but was able to perform monopodal weight bearing. And this is the patient in how it looked in the outpatient consult. So I did ask for the patient to, there was no plantar ecchymosis, but this is like how it looked like. And these are the weight bearing X-rays. So as it was said before, there's a gap between the first and the second metatarsal and the AP views, and you can see the difference between both sides. And I think this is really important to if you are thinking about different injuries, I think you must get this. In some countries already there's the availability of the weight-bearing CT scan. In my country, it's available. This is like an older case, but I think that the weight-bearing X-rays are fundamental in the treatment of and the diagnosis of Lis Frank injuries. And these are the lateral views. So here's something that I always tell my residents and fellows that about the proximal involvement of the Lis Frank injuries. So you always have to check out the tenonavicular, the intercuneiform, and try to establish preoperative if you will need to do some proximal fixation in these cases. So in this case, I think this is it's a Lis Frank injury, but I think in this case it's like a medium column dislocation. You can see over there the overlapping dorsal of the cuneiform. So if you get this on these are the first X-rays that we saw. You can see like here that this junction is, if you see it with like looking back, you may already seen that the medial column was dislocated. I don't know if anyone has any comments about the diagnosis of this.
Dr. Chen, are you on the line?
Yes.
Bonnie, what do you think?
I think this is definitely a subtle injury. I think at the beginning in the emergency room, most of the time, even here in the US, it's very difficult to obtain weight-bearing X-rays, let alone bilateral weight-bearing X-rays in the emergency room. So I think for some of the trainees on the line, I think it's very important to do a good exam. A lot of times in these injury, the pain seems like it's out of proportion really from just a midfoot sprain, and there can be significant ecchymosis at the plantar aspect of the midfoot. And I think that should really raise your alarm bells about this being a more severe Lisfranc type injury. We conventionally think that a Lisfranc injury primarily involves the tarsometatarsal joints and at what conventionally has been known to be the Lisfranc ligament between the medial cuneiform M1 and the second metatarsal. But I think it's a great point to note that this is a variety of injuries, and it can involve, as was said very eloquently earlier, that you can have more proximal involvement of the navicular cuneiform, of the intercuneiform, and even of the first TMT. So I think all those areas, I kind of think of it as like, you look around like a rectangle, you have to go kind of all the way around and not just necessarily focus on one aspect of the joint.
And so, Dr. Chen, how would you manage this injury? What would be your surgical approach? What are you thinking about? Like, what joints are you reducing first? Where are you putting your fixation?
So I think this person's around mid-40s, relatively young. I know there's literature suggesting that a primary arthrodesis in a ligamentous injury may have better outcomes in terms of one, doing better, and then two, like lower rates of heart removal subsequently. I think I typically probably in this case, where there is the cuneiform involvement, that I would plan to open reduce it probably medially, make a more extensile medial approach. And then I think I'd try to kind of spare the joints for the time being, like reduce the subsequent aspects of the midfoot joints. You can put a screw across what typically is the Lisfranc or the Lisfranc ligament is, maybe an intercuneiform, kind of span across the NC and the first TMT. The potential downside of that is that you probably may have to have the hardware removed later. But again, it's to get the joints reduced, the alignment, the medial column buttressed and maintained in length, and hopefully you can heal without, or at least delay the onset of arthritis later on. So I'd try to spare his joint in the time being.
And so your thought is like putting some fixation across the intercuneiform joint is gonna improve your navicular cuneiform, just sort of like subluxation that you're seeing here. That should reduce it and hold it.
Yeah, I think that should hold it. I mean, the other thing I usually do is before I even do any incision or fixation, I do a stress test of the foot. So I really try to see dynamically under, we usually here use a mini C-arm, so you can kind of manipulate the C-arm and get the position and the views that you want. And, I sort of dorsiflex, I externally rotate, I abduct through the midfoot to see where the instability is within the midfoot.
That's a great point. Well, Gonzalo, tell us what you did.
Yeah, actually, I got like similar thoughts like Dr. Shan. So in terms of what we do, I ordered a CT scan just to check out if there are any fractures that I had to take care of. Probably in this case, there was not like the fracture component, but I think the CT scan can help you out a lot in their intraoperative planning. I ordered a CT scan. There were no they had only avulsive fractures, and no anything bigger than that. There wasn't anything about it. So the thinking about the approach, I also thought like approach for this. Yeah. Okay. So let's go. So actually, here's the patient. Like 2 weeks, and there's some plantar ecchymosis just starting to appear. So yeah, I think the plantar ecchymosis is a very good sign, but beware that sometimes it can be very late. In this case, I use a medial approach, and here you can see the medial column being dislocated. I think I have a video. Yeah, I have a video. Sorry for the quality, but you can see that that's what we expected. Here are the toes. Here's the ankle. Let's go again so you can get it. And you can see how it's unstable and also intercuneiform. So we did this with the bridge plating, and we also threw a screw for the Listran screw. We used like a medium column plate, and this is the result. So we can span all the joints involved, and I also fixed the Listran. We narrowed the Listran space with a one cannulated screw. This patient did really good. And yeah, I told him that we probably had to take out the hardware at minimally 6 months. I usually take out the hardware. Like I told them that it's part of the procedure to have this taken out. Probably because they start like breaking the screws with some prominent plating, and usually these are the plates that usually bother the patient. So I just like include them in the procedure. I just tell them that we have to take it out like 4 or 6 months afterwards. I don't know if I have the X-rays without that. No, this guy moved to Brazil, so he had his hardware removal at 4 months there, and he resumed his sports activities and pool parties. So yeah, this is it. Thanks.
I think that looks great, and I think all extremely important points covered, Dr. Bastidas. I think one thing I would comment on is sometimes I've seen, depending on the chronicity of the injury, the initial instability, diastasis, sometimes I will make like another separate dorsal incision, I think as you were thinking about, because sometimes you get a great reduction in the medial column, it's out to length, the joints are reduced, but it's hard actually to access the Lisfranc joint between the medial cuneiform and the second metatarsal. So sometimes I will open it and actually really debride out that joint in order to facilitate the reduction as well. But sometimes you don't need to do that.
Yeah, I was thinking about that also, but and actually I thought that I would have to make that additional approach, but this was really larger than I thought. So I could see the Lisfranc joint with this approach, and I tried to debride and everything, so it wasn't necessary. But yeah, I had the same like the same issues, like thinking about that, like doing like double dorsal medial with being the dorsal like a small one, but just to take look at that reduction. But yeah, I totally agree with you.
Dr. Zayad, how would you have approached this? Would you have done anything differently?
Yes, for me, I will do for like Dr. Bastos do it if the facility is available. Reconstruct medial column by a mini plate, the same procedure.
And do you think it was, Gonzalo, was it necessary for you to go all the way to the talus in this case? The instability of the cuneiform was so great that you felt it was necessary to bridge all the way there?
Well, I was tempted to, but I thought that, well, I just take it out with also with a mini C-arm. We do the stress, and we see it on the direct side. And it didn't seem that there was any instability. And you can see like in the preoperative X-ray, that's really clear that that's where the energy went by. So even though this is I use a plate system that has all the different combinations for plating, all of you can do like shorter, bigger. We have that the exact same plate, but going into the talus, and it would be easier to do it, but we didn't think it was necessary. But yeah, you have to, sometimes there's also talonavicular involvement, but in this case, it was really clear that the energy went through there, the navicular cuneiform joint.
Really great case. Any other comments on this case? Go ahead.
I have Dr. Kiran, please. I have questions regarding if you give me, if you can.
Please go ahead.
I have questions regarding arthrodesis as a primary treatment of less frank fracture dislocation. When and where decided to make arthrodesis for the less frank fracture dislocation as a primary treatment?
Well, in my case, I think it's, I don't do arthrodesis so much in these cases. Mainly, I think it's, well, I did my fellowship in the US, and I think patients in the US accept arthrodesis a little more than in my country, in Chile. And this may be also because, like we were talking about later, early on the terms of calcaneal fractures. I think the arthrodesis in some subtle lesion, and I know that the literature has support this, can be better than the original open fixation and rigid fixation. I think I always give a chance on this, and I think that sometimes if you make the fixation and you go out and do your hardware removal, I think the results in my experience are very similar. I think there are some cases, specific cases, that you have to do the Listrang arthrodesis, but I think in general view, I think that in my experience, I try to always go with fixation and see where that goes. And always, if you're doing the fixation, try to remove your hardware, because like it has been said on multiple meetings, and like being like a hidden fuser, like leaving your hardware on, because if I leave this plate on in this patient, probably those joints will not be moving, and there's no difference with that with the arthrodesis.
Yes, thank you so much.
Sorry, just a quick one. Mentioning that, what would you remind them, what you warn them about the risk of arthritis, and what figure you quote them, bearing in mind leaving the risk that we end up with the stiffness if you leave the metalware, but what risk of arthritis will you give them?
What risk of arthritis? I think it would be, this patient is at a high risk of arthritis, but in this case that there are so many joints involved, probably one of them will not fuse in cases we do a primary fusion. And that's how I see it. And sometimes I have patients that they have like secondary pain, and sometimes you take out CT scan and you do some midfoot arthritis, and you take out the hardware, and you can go two ways. Sometimes this start moving and the pain becomes worse, or sometimes it was just the hardware that was, I don't know, in these cases, really rubbing the tibia and the tendons, and the patient gets a lot better. So I try to get it on a step-by-step basis. I try to leave my fusions for the last resort. And yeah, I think this is controversial. It's a controversial topic. But I think, I always try to join spur at least for the first year or 2 years.
Thank you.
Well, excellent. That was a really great discussion. Thank you, Dr. Bastias, for that great case. So I think that's our last case for the day. Are there any other questions from anybody before we sort of wrap up things for the day?
I think we have a case.
I thought there's another case.
Oh, there's
yes.
Yes. Oh, okay, great.
Yes.
Go ahead. Who's
last case? Yes, they are waiting.
Sorry about that. Go ahead, please.
Dr. Kabazi.
نعم دكتور أيمن.
أيوة. Share your screen, please.
Can you hear me?
Yes, clear.
Yes. Okay.
If you give us a permission to share our screen, please.
There you are. You should have it now.
Dr. Kabazi and Dr. Mustafa Al-Kattaf, they are very active surgeons from Muslitan Hospital, and they do all very good job.
Thank you, Dr. Ayman, and thanks for all faculty members. Our case today is. Can you hear me?
Yes.
Yes.
Clear. We can hear you.
Our case today is a case of revision malmanaged or flexible painful flat foot. About the personal data, she is 16 years old, female, Libyan student, single, chief complaint, painful walking. She from previous 3 years back, she came to us with painful flexible flat foot. After that, she went outside country and they did calcaneocuboid arthrodesis without flat foot correction. This is the X-ray. This is the X-ray. When we do examination by inspection, limping at walking, rigid, painful flat foot, can't do heel rise test because of pain, surgical scar lateral side over calcaneocuboid joint. There is severe point tenderness at subtalar and talonavicular calcaneocuboid joints, painful range of motion, active and passive in hind and middle foot. X-ray shows severe osteoarthritis, subtalar joint, talonavicular osteoarthritis, calcaneocuboid arthrodesis with stapler in fixed flat foot position. We did radiographic X-rays, AB lateral for both ankle and foot, laboratory, CBC, biochemistry, all are within normal limits. Our diagnosis is severe osteoarthritis subtalar joint, talonavicular osteoarthritis, calcaneocuboid arthrodesis in fixed flat foot position. What is the best plan of management?
I think we will open post the presentation and we will open the floor. What do you think, Dr. Kiran?
Well, why don't I ask people who are more intelligent than me?
Yes, that's okay.
Dr. Ken, do you have any comments on this case?
So this is definitely a bad problem. Yeah. And how old is she now? I mean, she's still really young, obviously. I mean, it's only been
16 years old, as he said.
So I think, yeah, the arthritis is pretty clear. I think when we have the resource, usually what I would get is a CT scan just to really assess the status of the joints. I think the first point is when you have a younger patient, I think as you're probably alluding to this case, I think we probably would have thought to do something different than calcaneocuboid arthrodesis in a young patient who likely did not have arthritis. And what happens when you primarily fuse a joint is that now there's adjacent joint arthritis as you lock up one joint, and then the other joints have to take more load and stress. And then now basically her entire hind foot is stiff and arthritic. And I'm sorry if I missed this. Did you mention if she still has a flat foot deformity? Like basically the deformity wasn't really corrected, even though the calcaneocuboid point was fused. That's what it sounds like. Is that correct?
Yeah, I believe so, Dr. Chen. I think that they described that it's still in a fixed flat foot position after this fusion.
Painful flat. painful flat foot.
Flat and stiff.
Yes.
Yes, the result of the previous surgery, which is done with another doctor, which
Yes.
Which he's do calcaneal cuboid in flat foot position. I think he don't correct the deformity and the cause of pain. That's why he came to us, because he's disrupt the biomechanic of the foot at all.
Exactly.
That's why after two or 1.5 year, he's come to us with this picture, with severe distortion of the joints of the hind foot. Okay, we'll proceed. With what we do for her.
We planned for triple arthrodesis with correction of the flat foot. The procedure was lateral incision, same old incision, and stable removed calcaneocuboid osteotomy. We did calcaneocuboid osteotomy, and we did the medial incision to exposure talonavicular joint. Cartilage was removed. Subtalar joint also prepared, which fibular strut graft harvested and inserted at calcaneocuboid osteotomy site. We did some like Ivan concept. Calcaneocuboid compression done by 1 Acutarc headless compression screw 5 mm, 1 for talonavicular joint and 2 for subtalar joints. This is the immediate post-operative X-ray.
Nice, it looks good.
I think I agree with your approach. I think even without necessarily having access to a CT scan, it's a discussion to be had with the patient that given she's already stiff and arthritic, the triple arthrodesis would be probably the most reliable in terms of pain relief without undergoing a huge reconstruction like a more typical flat foot surgery that's joint sparing. I think you were thinking about all the right points of when she initially had the calcaneocuboid fusion, that can shorten the lateral column with the fusion. And it's, if I'm understanding correctly, with the osteotomy, either at the joint or even in between the anterior and middle facet of the calcaneus, that you can try to do a lateral column lengthening of sort through the fusion even to try to achieve more length in that area laterally.
I can't understand if she is asking me about the procedure.
No, what she's trying to say. I think you obviously done a great job. You addressed the deformity and you addressed the problem with the lateral column shortening because of the previous effusion. So you addressed the original problem and the second operation problem. Is that right, doctor?
Yeah, no, I think that's great. I was just clarifying when you were saying calcaneocuboid osteotomy, what kind of osteotomy you did in terms of the fusion site, or you were trying to lengthen across that area as well. With the wedge.
Yeah, I think.
Do you have a clinical? Sorry, do you have a clinical picture of the foot? Or
yeah, please. Go instead if you have it.
This is the immediate postoperative X-ray.
No, photo of the foot.
Post 3 weeks follow-up. This is the X-rays post 3 weeks follow-up, and we have a video for range of motion after 3 weeks. This is full range of motion, free of pain.
So that's ankle joint pain free. Yeah.
And were they able to walk without pain?
Yes. She can walk.
Yes. This is post 35 days follow-up. This is the X-rays post 35 days, and she is walking after 35 days.
Well, that's a very tough case that you've shared. Really
Yeah,
difficult to reconstruct, but you know, as good as an outcome as you can hope for someone who had such a tough problem. So no, I think that's a great case. Thank you for sharing it.
Well done, guys.
Thank you.